My name is John, and I'm a scientist in the Thompson lab here in Madison, Wisconsin. And I'm going to give a overview of our efforts to generate small diameter synthetic blood vessels using ES-derived arterial endothelial cells and EPTFE vascular grafts. And we've also developed a arterial bypass model in rhesus macaques to test these grafts out. So for this talk, we're going to focus on peripheral vascular disease. Um, However, we hope that maybe someday this may be therapeutic for cardiac bypass as well. So peripheral vascular disease is estimated that affect 8 to 12 million people in the United States and 200 million people worldwide, with the annual mortality incidence predicted to rise to over 23 million by 2030. Okay, so the peripheral vascular disease is a severe obstruction of the arteries that restricts blood flow to the extremities. This leads to severe resting pain in feet and toes, and during later stages of the disease, patients develop sores and wounds that don't heal. Current therapeutic interventions include angioplasty and stenting or vascular bypass to bypass the obstructed part of the vessel. Current options for vascular bypass include autologous biologics such as artery and veins or prosthetics. The preferred vessel would be arteries, since you're bypassing artery is preferred method. However, they can include radial arteries or internal thoracic arteries. They have superior patency, but they're also more challenging to harvest. There's limited length of arteries compared to veins, and they are more prone to vasospasms. So I would say the most common graft used, the biologic graft used for peripheral bypass is the greater saphenous vein, which has moderate patency of over 70%. It's easier to harvest, although you still have increased operating time, some wound healing, and there's still limited supply. So these are reserved for more pressing indications. And with both artery and veins, it's still limited by pathophysiological condition of your patient, which a lot of the times patients with peripheral vascular disease may not have suitable blood vessels to use to begin with. In this case, surgeons may have to go to a prosthetic method. Most commonly used is EPTFE or expanded polytetrafluoroethylene grafts. Although their patency rates leave much to be desired. Above the knee bypass is only 50% of 5 years, while below the knee, you're only seeing 20 to 30% patency. They do suffer from relatively high rate of thrombosis and the occlusion through myotubular hyperplasia, and they are much inferior to autologous grafts. Given these limitations of these synthetic grafts and patients that may not have suitable autologous grafts to use, methods have been looking at to improve the patency of EPTFE grafts. And I'm showing you here, these are previous ongoing clinical studies from groups in Austria that show that improvements in patency have been achieved by seeding autologous endothelial cells onto the lumen of EPTFE grafts. I'm showing prosthetic grafts of both an 8-year prosthetic graft patencies of both an 8-year follow-up clinical study and a 15-year follow-up in a clinical study. And as you can see on the left side here, untreated graft placement patients tend to fail by 6 years, whereas the endothelialized grafts perform pretty well comparable to vein grafts. And even a 15-year follow-up, you see a 90% limb salvage rate in over 300 patients. This is still not without its limitations, is that if you're going to seed EPTFE grafts, you need to harvest endothelial cells from the patient and expand in tissue culture still. So we are aiming to create a more off-the-shelf product by using ES cells to derive arterial-specific endothelial cells and line ePTFE grafts. So the general strategy for us is to take ESLs, differentiate them to arterial defined endothelial cells, seed these endothelial cells onto small diameter ePTFE grafts, and then we would like to test these grafts in a interposition graft femoral arteries of rhesus macaques, where we compare naked ePTFE grafts alone to sterilized versions of these ePTFE grafts. And these will be relatively short studies for 6 months, so we will follow patency and explant the graft at endpoint or upon failure. So I'm showing you here first, the first step is to make functional arterial endothelial cells. And this data is already previously presented by Zhu Zhang in our lab, and it's been published, where we have a protocol to establish arterial defined endothelial cells with high purity. If you're looking here, you're seeing the expression of the mature endothelial marker CD144 and the arterial specific marker DLL4. These cells are functional. These arterial cells compared to venous cells have nitric oxide production. These arterial cells compared to venous cells show a shear stress response as well as low leukocyte adhesion when treated with TNF alpha. One issue that's come up with this protocol to make these endothelial cells is that once we split these and put this in a maintenance media and tissue culture, we notice that over time we start to lose expression of both arterial marker DLL4 and the endothelial marker CD144. And if you look at the tissue culture plates, you see colonies popping up of cells with different cell morphology that begin to overtake these endothelial cultures. And if we do some sequencing in between these two cell types that are coming up, you can see that these contaminating cells are growing in our tissue culture preferentially expressed mesenchymal markers. So there's a mesenchymal population that's taking over our AC culture over time. I'm not going to go into all the details, but we spent some considerable time trying to eliminate this contaminating population. That included both RNA-seq analysis and high throughput screening or small molecules to either make our endothelial cells happier or get rid of the contaminating cells. I can say that with limiting success, that some small molecules are able to inhibit contaminating cell growth, but however, over time they still come back and are not totally eradicated. So we finally set on this strategy of removing our contaminating cells. So instead of trying to remove these cells with small molecules or growth factors, we genetically engineered our ear cells to express puromycin resistance driven by PCAM expression. PCAM is preferentially expressed in AECs. And as you can see down at the bottom left here and bottom right, that if we take ESLs that contain this cassette and we make AECs and we treat with Piro, we can maintain a high purity population of endothelial cells over time. This is data up to day 35 post-split, and we've carried it all the way up to 60 days. And we can maintain 90% purity over this time. So now that we have endothelial cells that we can maintain at high purity, the next step is cell attachment to our ePTFE grafts. So ePTFE grafts are made from PTFE, which is polytetrafluoroethylene, that's been heat and stretched into tubes. As you know, that PTFE is used for Teflon and Gore-Tex in your coats, as well as these grafts. And it's a very hydrophobic material, so it has lower cell adhesion to it. So we spent some time finding different coating strategies to improve cell attachment of endothelial cells to these grafts. And one such strategy is inspired by mussels, which secrete proteins that can bind to any surface. Um, and from these studies, dopamine was shown to be a good mimic of essential components of muscle adhesive proteins. So once again, I won't go through all the cell attachment strategy. I will just say that we can treat our ePTFE grafts with dopamine for 16 hours. And we also add a second coating of vitronectin to these grafts. We can get efficient and more consistent endothelial attachment to the inner lumen of these ePTFE grafts, as shown here, with CD31 staining. So we have a source of arterial defined endothelial cells, and we have a attachment strategy for putting these cells onto these synthetic grafts. The next step is we want to develop a model where we could test these grafts out. So we developed this femoral bypass model in collaboration with surgeons here at UW-Madison Hospital, and we chose the superficial femoral artery as the segment artery we want to bypass. And this comes from the common femoral artery that splits into the deep femoral that feeds the upper thigh and the superficial femoral artery that feeds the lower leg. And we needed a artery with decent size since the smallest commercially available ePTFE grafts are 3 millimeters in size. And we performed a few pilot experiments, and we can show that the superficial femoral artery in these monkeys ranges anywhere approximately 2.5 to 3 millimeters down to 2 to 2.5 millimeters distally. So size approximates that what we have for the grafts. And we want to proceed. And we started by performing implants with just naked ePTFE grafts. So here you see one of our first surgeries. This is a ePTFE graft, a 4-centimeter segment that is going to be placed in a position graft into the SFA right here. They clamp each end and they mark a segment to take out, and the graft is sutured in place and blood flow is confirmed. And then patency of these grafts is followed by ultrasounds, which the nice thing about ePTFE grafting is if you look at an ultrasound image of the graft, you see this double wall the structure of the walls there. So they're easy to detect exactly where they're at. And we can follow graft patency and nice triphasic waveforms, as well as peak velocities. So using ultrasounds every 2 weeks, we carry these studies off for 6 months. If the graft fails by ultrasound, we schedule explant immediately afterwards. And the next, I'm going to give you a couple of examples of what we're seeing when we take these grafts out. So this is an example of a naked graft that failed at 1 week post-op. You can see by ultrasound, there's no waveform signal at all. I'm showing you a cartoon figure here of the SFA with the graft in place and what sections we're looking at. And just grossly can see that this failed by thrombosis. You can see the clot of blood within the graft already. And then in our second example, so most of the grafts that failed, for most of the naked grafts that failed are failed by this thrombosis, which as I mentioned is an issue with the synthetic grafts to begin with. Grafts that do make it to 6 months, this graft is perfectly patent at 6 months, and when we explant it at 6 months, while patent, we still see a measurable amount of myotumoral hyperplasia that's forming within this graft. So although I don't know if this will remain stable over long term, at 6 months, it looks like it could fail within the first year. So these are just a couple of examples of what we're seeing. We're seeing thrombosis in these grafts, myotumoral hyperplasia. This is all known to occur in these ePTFE grafts. So of course, I'm gonna end on this final slide. Well, I'm sorry. The other thing we were interested in is if cells are infiltrating into these grafts. So I also have done some staining, and we're looking at endothelial markers CD144 and CD31 here. As you can see, we do see endothelial cells kind of going into the lumen, but you only see them a few millimeters within the proximal and distal ends. The middle of the graft is all completely empty, so cells are only infiltrating very briefly into this graft, and the rest of the graft remains empty. So using this model, this is my final slide where I'm going to kind of show you where we're at currently and where we're going in the near future. We've already begun to test cellularized grafts, and I'll just show you that our first comparison we want to make is between ES-derived ACs from wild-type cells, and these are the purified cells, and then compare that to cells that would mitigate immune response. So we've knocked out beta-2 microglobulin and C22TA, and to try and knock out MHC class 1 and 2. And what you're looking at here is, as I mentioned, all the naked grafts that have failed within the first 5 weeks. They've all failed by thrombosis pretty much. And then and by 6 months, we have only just a little over 40% patency in the naked grafts. We've had 6 animals that have gone in where we put in wild-type AECs into the ePTFE, and we're still seeing 100% patency in those animals. We still have 2 animals left in this group, and we have just started putting grafts that have been lined with double knockout AECs in them. So we'll be able to look at if immune response plays anything to this, but based off initial results, it shows that endothelializing these small diameter grafts greatly improves graft patency. So with that, I'd like to thank everyone in Thompson Lab. I'd like to thank our surgeons as well as staff at the Wisconsin National Primate Research Center, and I can take any questions.